Welcome everyone to tonight's webinar entitled Eating Right, Easing Symptoms of Constipation with Diet. This webinar is a part of a Digestive Health series that we put together this summer, where we discuss dietary therapy for various disorders affecting our GI tract. Tonight's presenters are Dr. Leila Neshatian and Ms. Sandy Sun, who work in our Digestive Health clinic. Dr. Neshatian is a pelvic health expert with motility interest among our faculty. And Ms. Sun is one of our dietitians who take care of patients with constipation at the center. Now I'd like to introduce Dr. Neshatian.
Hello, everybody. Thank you, Dr. Kim and Stanford Digestive Department for providing this platform to educate our community. And also, I want to thank you all, our guests who are here to spend this next hour with us to learn about eating right, easing symptoms of constipation with diet. So let's start with some basic definitions. What's constipation? Chronic constipation is characterized by unsatisfactory defecation and difficult or infrequent stools. It's a functional GI disorder that leads to difficult, infrequent, or incomplete defecation. Majority of patients with constipation have infrequent bowel movements or hard and lumpy stools. Some patients with constipation, however, may report having multiple soft bowel movements a day, but they have significant need for straining or have the sensation of obstruction or inability to pass the stool. In some extreme occasions, some patients may need to manually evacuate their rectum. So presence of any of these symptoms that are persistent during the bowel movements is considered to be constipation. We know very well that constipation affects the daily life and increases the psychological distress and impairs quality of life. And also, it's a very common problem in the whole world. The prevalence of chronic constipation globally is estimated to be at 14%. Its prevalence in the United States has been estimated to range from 9 to 20%. It's much more common among women and older individuals. However, from a very recent large survey of Americans, we learned that 3 out of 5 Americans who have been suffering from the symptoms of constipation have never discussed their symptoms with a healthcare provider. And that's why it's important to talk about the symptoms of constipation, some of the common causes, how to alleviate the symptoms with diet and lifestyle modification, and when is the time to see a doctor. Constipation can arise from various other pathologies and diseases. The more common ones include neurological disorders such as multiple sclerosis, Parkinson's disease, stroke, and many more other chronic neurological disorders. There are a number of medications, such as pain medications, who are associated with significant side effects of constipation. Over-the-counter pain medications have been also known to cause constipation. Blood pressure medications and some of the antidepressants are associated with constipation as well. A lot of other chronic diseases, such as chronic kidney disease, hypothyroidism, diabetes, are also all known to cause some degree of constipation. But in majority of patients who have constipation, this is a primary problem, and the pathophysiology is not completely understood. We think that the reason for constipation in primary constipation is because of the abnormal function of the nerves and the muscles that are causing abnormal motility and hypersensitivity. But truly, we don't know the exact problem and what is going on in these cases. Majority of patients who have constipation, the symptoms are mild and they are amenable to management with diet and lifestyle modification. There are some patients who have more moderate or more prominent symptoms, and they may need to have some testing, evaluation, and use the laxatives to improve their symptoms. And there is only a small group of patients who will have really severe symptoms. And in these patients, we may need to really have a multidisciplinary approach with several teams involved. Well, what's the role of diet? And when should we talk about diet in patients with symptoms of constipation? When we talk about constipation and diet, the first thing and the most important thing that comes to mind is fiber. Fiber is the edible parts of carbohydrates that resist digestion and absorption in the small intestine. Based on the interactions of the fiber with water, it is classified into water-soluble or insoluble. In the next half an hour, Sandy will go over the details of the fibers that are helpful for the symptoms of constipations, and not all the fibers are the same. How fiber affects the GI function? So, supplementing the fiber in the diet will benefit by increasing the bulk of the stool and stimulate peristalsis. At the same time, fermentation of the fiber in the colon by the bacteria that is in our colon can increase the stool water holding capacity and form gels that is providing some stool lubrication, at the same time increases the biomass. One side effect of fermentation of fiber in the colon is going to be gas production. And this gas, whether this is methane or hydrogen or CO2, can aggravate abdominal pain and bloating. So specifically in patients who have abdominal bloating, and if they have irritable bowel syndrome with significant abdominal bloating, the fiber can be a problem. And in these patients, they may not be able to really take fiber to improve the symptoms of constipation. Indeed, in many of these patients, we may consider a FODMAP diet. This FODMAP diet was covered by my colleagues in the previous talks, and Sandy again will talk about it in the next talk. But I just want to point out the reasoning behind the FODMAP diet. FODMAPs stand for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. As you can see, many of the oligosaccharides and disaccharides are indeed the fibers that are good for symptoms of constipation. However, the thought here is that when these elements get to the colon or the large intestine, they go under fermentation and again cause significant abdominal bloating, and gas production can be really uncomfortable. And by eliminating these elements from the diet, the symptoms of the gas, bloat, and IBS will improve in the patients who have significant abdominal symptoms. So despite the fact that we want you to be on diet high in fiber, in some patients who have significant abdominal bloating, this might be the reason to go for a FODMAP diet. Regarding the adjunctive approaches, and again, this is going to be covered in the next talk, I want you to stay hydrated. This doesn't mean that I want to try to treat your constipation with hydration, but the fact is that we know low liquid consumption is known to be a predictor for constipation. So you want to avoid any dehydration. Physical activity is very important as well. Exercise is recommended for chronic constipation. And this is based on multiple studies involving 680 participants. The effects of exercise is thought to be through modulation of anti-inflammatory and antioxidative mechanisms. Therefore, I want you to increase your physical activity as it's tolerated. Start with simple activities. If you can, take up to 20 minutes walk a day. And from there, you can increase it as you may want. Some other simple approaches, such as correct positioning using a squatting stool that will elevate the knees and the hip and align the rectum and the anal canal, can be very effective as well. Diaphragmatic breathing with increasing intra-abdominal pressures can be very effective in improving the push and therefore better evacuation. Practicing mindfulness, being aware of your sensation rather than postponing the urges for having a bowel movement, can be one of the most important parts of the treatment of the constipation. But how about the patients who have been on top of all these and still have the symptoms that are not optimally controlled? This is the time to talk to a healthcare provider. When I assess my patients with constipation, I want to know about the duration and nature of their constipation. We often use the Bristol stool form, and the scale is a validated tool that can assess the stool consistency on a spectrum of 7 types. It can be very useful in clinical practice. Type 1 and 2 stools are usually hard and lumpy stools, and type 6 and 7 are usually going for watery and loose bowel movements. The stool consistency has been shown to be more reliable than the stool frequency in terms of predicting the colonic transit time. I also ask about the other GI symptoms. If they have abdominal pain, abdominal bloating, or vomiting, we will ask about the alarm symptoms. The alarm symptoms include any significant rectal bleeding beyond the hemorrhoidal bleeding, any unintentional weight loss, a person who has a family history of colon cancer or Crohn's disease or ulcerative colitis may be at increased risk. And also, if this is a constipation that has been newly bothered in an older person and there has been no history of previous colonoscopy, these are all concerning to me. In the abdominal exam and rectal exam, we look for any masses. If there are any lymph nodes, we are going to be really looking for them. Other than these alarm features, in a person or a patient who doesn't have any significant symptoms, the yield of diagnostic colonoscopy is going to be very low. And there is no really a good reason for us to pursue a significant endoscopic examination or cross-sectional imaging. And I know when it comes down to constipation, the concern for all of us as healthcare providers and our patients is really presence of a colon cancer that is obstructing the colon and causing the symptoms of constipation. But this slide is to show you that we have looked into this matter many times. This is a meta-analysis. Otherwise, this is a study that pulled the data from 8 other large-scale studies together to look for the risk of colon cancer in people who have had constipation. And as you can see, there was no association between chronic constipation and development of colon cancer. So the purpose of this slide is to give you some peace of mind that not every constipation is concerning. Let's talk about the subtypes of constipation. There are 2 major subtypes of constipation. One is the slow transit constipation, and 2 is the pelvic floor disorders. There are a group of patients with significant abdominal pain and bloating in each group, and these are the patients who are considered to have irritable bowel syndrome with constipation predominant symptoms. Let's go over each group in more details and start with slow transit constipation. In a slow transit constipation, the problem is within the colon. We know that within the colon, there are 10 to 12 times of high amplitude contractions that are activated in 24 hours. They're mainly activated after a meal and after waking up in the mornings. Once they are activated, they are responsible for pushing the stool mass throughout the colon to the rectum. And they are really responsible for causing proper contractility and peristalsis in the colon. If there is any abnormal contraction, this can be associated with slow transit constipation. To assess our patients for slow transit constipation, we have a couple of tools. One of the oldest and the easiest is this marker capsule. There are 24 small rings in the capsule that the patient will swallow and take an X-ray 5 days later. We count the number of the markers that are retained in the colon, and if there are more than 20% of these markers still in the colon after 5 days, this is considered slow transit constipation. The other study that we can consider is called wireless motility capsule. This is a bigger capsule that the patient will swallow. As it goes through the GI tract, we'll monitor the pH, acidity, temperature, as well as the contractions. And after 5 days, we will download the recording and we will be able to estimate the transit time in each part of the GI tract and see if there is any evidence of a slow transit constipation based on the recordings. In some centers, mainly bigger academic centers, they may be able to use scintigraphy for evaluation of the colonic transit as well. The other group of patients with constipation have pelvic floor disorders. The pelvic floor disorders comprise 50% of patients with constipation. These are the patients whose reason for constipation is inability to relax the anal sphincter muscle. These are the pictures of the lateral view of the pelvis. As you can see, the rectum is leading to the anal canal covered by three muscles: external anal sphincter, internal anal sphincter, and the very important U-shaped muscle that is called the puborectalis. The puborectalis is essential for maintaining continence. It's the one that is responsible for maintaining the angle between rectum and the anal canal called anorectal angle. When one is trying to have a bowel movement, along with the contraction in the rectum, there should be relaxation of the external, internal, and puborectalis muscles. If any of these functions do not happen, the relaxation of the pelvic floor muscles of the anal sphincter does not happen at the time of the evacuation. This will lead to significant constipation. In some patients, at the time of defecation, they may inadvertently squeeze the puborectalis muscle, and that's really when we call dysenergic defecation. Evaluation of patients with dysenergic defecation or pelvic floor disorders can be done by a variety of probes that are called anorectal manometry probes. These are simple tools that will be monitoring the anorectal pressures at the time of simulated defecation. We can sometimes use imaging, including MRI or X-rays, and visualize evacuation at the time when the patient is trying to empty their rectum, and even use the ultrasound for further assessment of the anorectal function. In patients whose problem is mainly in the pelvic floor muscles, the best evidence-based therapy is biofeedback and physical therapy. Biofeedback is instrument-based learning. And here the physical therapist will use, depends on where you are, a probe, the rectal probe or vaginal probe, to teach you how to relax the pelvic floor muscles and the anal sphincter muscles and have a coordinated contraction of the abdominal muscles when you are trying to relax the anal sphincter muscles, and this is going to lead to proper evacuation. Another major treatment for constipation is the use of laxatives. Constipation should be managed in a logical, stepwise manner with the laxatives. They are often over-the-counter, readily available, and cheap. We often start with the stool softeners in terms of their efficacy. They are not really effective in improving the symptoms of constipation. The stool softeners are sometimes thought not to be better than the placebos, and they don't really add much in terms of the treatment, but they are not really causing any side effects either. Osmotic laxatives, on the other hand, are very effective laxatives. The three major categories in this group include polyethylene glycol. You may know it under Miralax or any other store brand on this category. Different magnesium salts include magnesium hydroxide, magnesium citrate. They can be in different formulations, liquids, capsules, tablets, and they are very effective as well. The lactulose is the sweet prescription medication. The limitation of the use of lactulose is going to be significant bloating because it's a carbohydrate that is formulated in this medicine. These medications can cause some degree of loose stool, and that can be titrated based on the dose of the medication. And if we don't really find them effective in terms of management of the symptoms of constipation, we can move to use stimulant laxatives. Stimulant laxatives are also very commonly used. They are very safe. The major common side effect is significant abdominal pain and cramping, and also causing loose stools. The two major categories here include Visacodil, which you may know as Dulcolax, and Senna, that is the main content of the tea bags that are also giving laxative effect. These medications are sometimes used as rescue medications. In other words, if there is no bowel movement after 2-3 days, they can be used. They can be in the form of Bisacort, can be in the form of the suppositories, and that can be very effective as well. This is very safe in terms of the long-term use. I know that unfortunately many of my colleagues and the pharmacists may warn the patients of potential dangers of long-term use of these medicine, but in reality we have not been able to find any of these, and this is more of a misconception. If these medications are not effective, then we can move on to the prescription medications. Pro-secretory agents are the medications that are working on the ion channels of the intestine, drawing the electrolyte as well as significant water to the intestine, and this is how they cause the stool to become loose and also increase the peristalsis. The three major families here include lubiprostone, you may know it under Amitiza in North America, linaclotide or Linzess, and plecanatide or Trulance. The major side effect here seems to be loose stool that can be limiting their use in some patients. The second category here is prokinetic. The prokinetics work on the muscles and enhance the contractions. The two forms here are tegoserod and prucalopride. They can be used in selected patients, and the major side effects with the interaction with the ion channels of the heart or arrhythmias have been the limiting factor in their use. So I didn't talk much about the probiotics in the treatment of constipation. There is really little evidence for the use of prebiotics or symbiotics in IBS or the constipation. The best evidence comes from the probiotics, and even there, it remains unclear which combination, species, or strains should be preferred for each individual patient. And they are usually recommended for patients who have also abdominal symptoms and they have IBS. But if there is one that is helpful and you find it to improve your symptoms, you should definitely stick to that one. There is little role for antibiotics in patients who have constipation in terms of their best evidence is for people who have irritable bowel syndrome and again with no constipation. So constipation is common. Lifestyle and dietary modification is an essential part of management of constipation, and persistent symptoms may need further evaluation by a healthcare provider. Thank you for being here. With this, I will pass on the baton to my colleague Sandy to tell you about the fiber and all the dietary measures. Thank you.
Thank you, Dr. Nishatian. I'm going to be going over diet and lifestyle therapies to help improve stool consistency, as well as some potential diet changes to help improve symptoms related to constipation, such as bloating, cramping, and excessive gas. There are a couple different factors that can help improve constipation. I'm going to be discussing fiber intake, adequate fluid intake, physical activity, and mindfulness. So some background information on fiber is that a low fiber diet is about 10 to 15 grams of fiber a day. And that's actually what the average American eats. The USDA recommendation for fiber is 21 to 25 grams for women, and then 30 to 38 grams of fiber a day for men. So you can see that there's definitely a gap between how much fiber the average American is consuming and what's recommended. There are a couple different ways to classify fiber. One of the most common ways is to divide them up into types of soluble fiber and then types of insoluble fiber. Soluble fiber is kind of, if you think about a powder that you put into water and it thickens that water, so it kind of helps bulk up the stools. And then you have the insoluble fiber, which helps speed up the transit of food in the digestive tract, and that can help with constipation. So below, I have some examples of each one. So types of soluble fiber are apples, applesauce, bananas, tapioca, mashed potatoes. And then you have your types of insoluble fiber. Some examples of are whole grains, legumes, wheat bran, raw fruits and vegetables, especially the peels and the seeds. I do want to make a note that fiber, you want to be careful with your fiber intake. A lot of my patients who come with constipation have been told time and time again to increase fiber. And while that often is the case and it can be very helpful in constipation, I don't usually recommend changing your fiber intake significantly at one time. If you want to increase fiber, I would recommend increasing it slowly. Also, if you do have a history of bowel obstruction, if you have severe gastrointestinal motility or severe narrowing of your gastrointestinal tract, don't increase fiber and consult with a medical healthcare professional first before you consider doing that. Going back to the slide from before, I want to show a picture on how fiber can help with constipation. So if you think about your intestines as a tube and then the fiber is the wheel. So if you're taking in enough fluids, you have good physical activity, your GI motility is, it might not be optimal, but it's good enough. Then what happens is that wheel, the tube is tipped and the wheel kind of helps move the stool through, and that's where that fiber can help move the stool through. However, if there are other factors that are not optimized, like you're not taking in enough fluid, you don't have enough physical activity, your gastrointestinal motility is very poor, then what can happen is that fiber can accumulate in your intestines and then it can get kind of stuck there. So that's kind of why fiber can help, but then sometimes fiber can hurt. There are some types of fiber that can cause more gas. So these foods, even though they can help potentially with constipation, they can make other symptoms worse. Some examples are inulin, chicory, whey fiber, wheat bran. When I recommend fiber, if it's appropriate for patients with constipation, I tend to recommend sources of fiber that are less gas producing. So with the goal of improving the constipation, but not increasing bloating or increasing gas. These are some examples of fiber that are less gas producing. So chia seeds, quinoa, brown rice, nut butters, nuts, cashews, and pistachios. And later in the presentation, I'm going to have a slide that focuses more on the types of foods that can have more gas and ones that produce less gas. If you're eating a low fiber diet, don't suddenly increase your fiber intake. Don't suddenly start having a lot of brown rice, a lot of chia seeds, potato skin, quinoa all at one time. You want to increase it slowly. So for example, start with just the brown rice, having it a couple of times a week, and then slowly incorporate some quinoa. Sometimes if you do too much at once, it can be a little tough for your intestines to adjust to that. If you want to look for high fiber foods, good sources of fiber contain about 2 grams per serving or more. Next, I'm going to go over some types of fiber supplements. I will be mentioning some brands, but this is by no means an endorsement from Stanford Healthcare on these brands. These are just some common brands that people take, so I want to provide some information. The first one I'm going to discuss is psyllium husk. It comes from the seeds of the herb Plantago ovata. It's a soluble fiber and also a bulk-forming laxative, so it draws fluid from your body into your intestines, softens the stool, and helps it move through your intestines better. If you are going to start slowly. So for example, half a teaspoon and 8 ounces of water a day, and then increase as needed and as tolerated. Sometimes it can interact with some medication. So Try to take it at least an hour before or 2 to 4 hours after taking other medications. And then fiber and fluid intake, you want to make sure that you're drinking enough water to also help move that fiber through as you're increasing your fiber intake. Metamucil, I'm sure a lot of people have heard this is a pretty common fiber supplement. Its primary ingredient is psyllium husk. It doesn't work for all of my patients. Some have complained that they have more gas and bloating, and I looked at the ingredients, and oftentimes there are like sucralose, maltodextrin. Because it's not the pure psyllium husk, it has other things that can contribute to some symptoms. Citrusel is another one that is commonly recommended. So this type of fiber, it's called methicellulose fiber, and it's also a bulk-forming laxative. Another one that many people take for constipation are prunes and prune juice. Prunes work because they're high in insoluble fiber. Prune juice is actually filtered, so there's not as much fiber in it, but both are high in sorbitol, and that's a type of sugar alcohol, and it has a laxative effect on the digestive tract, so it also draws fluid from the body into the intestine. However, sorbitol can cause bloating and gas, so this is just something to be careful of. If it works for you with your constipation and it doesn't cause you bloating and gas, that's great. But I would just, if it does, that might be the cause. And just kind of, you can also even adjust the amount to find a balance between one that helps your constipation, but an amount that won't create too much bloating. Another food that has been coming up in studies to help with constipation is kiwi. So here I've noted about 3 studies. So one study conducted in healthy adults, that those with constipation predominant IBS, showing that eating 2 kiwi fruit a day for about 4 weeks increased defecation frequency, reduced colonic transit time. There's another study with healthy elderly people without IBS that showed that a daily consumption of kiwi fruit led to bulkier and softer, more frequent stools. All of these studies have shown a beneficial effect in terms of stool output and constipation, and there haven't really been any harmful side effects with this. Why does it work? They're not entirely sure. It may have a higher water holding capacity. It makes the stool more bulky and softer, promote laxation. And then some animal studies have also suggested that the enzyme actinidin may play a role in promoting laxation, but they haven't confirmed these in human studies yet. Aside from the fiber intake, I also want to emphasize the importance of fluid intake, especially right now. It's the summer, so we tend to sweat more. If we're more active, it can definitely predispose us to becoming dehydrated. So dehydration is one of the most common causes of constipation. So you want to make sure that you're drinking at least 6 to 8 8-ounce glasses of water a day. And I do want to be cautious with caffeinated beverages such as soda and coffee, because they are a type of fluid, but because they're a diuretic, if you drink too much and you're urinating it out, then that can also cause some dehydration. Exercise is often a piece that may get overlooked, but exercise is really important in increasing the muscle activity in your intestines to help move that stool through. I usually recommend having some type of activity within your physical capability most days of the week, if not daily. However, I am aware that this isn't always appropriate for everyone, depending on their medical condition or other issues that may have. So if you do have some hesitation, or if you're some issues with that, I'd recommend talking with your doctor or a physical therapist before starting an exercise regimen. In terms of the mindfulness, don't ignore the urge to have a bowel movement, because the more you ignore it, the more you train your systems and your muscles to not allow that stool to pass. Also, making sure that you take your time in the bathroom, allowing yourself enough time to have a bowel movement so that you're able to relax your muscles without distraction and without feeling rushed to pass that stool. Some patients have also found using a squatty potty help. It's basically a stool that you put around the toilet and put your feet on it so that you're in a squatting position as you're having a bowel movement, and that puts your intestines in a better position and your muscles in a better position to help evacuate the stool. My next section, I'm going to go over some ways to improve symptoms associated with constipation, mainly focusing on bloating and gas. So many of my patients talk about bloating as a really significant symptom. It affects their quality of life, and it often gets worse later in the day. So if you think about the more foods that you eat, moves through the intestinal tract, gets digested, and all that gas gets created. When you're constipated, it's harder for that gas to move through, and it can stay there and really exacerbate the bloating symptoms. The term that I'm referring to in terms of foods that can help or hurt is high versus low FODMAP foods. FODMAPs is an acronym. It stands for fermentable oligomonosaccharides and polyols, and they're basically types of carbohydrates that we don't digest or break down, but when we eat them, they move through our intestines and then get fermented by the bacteria in our large intestine. And when that fermentation occurs, it creates gas. And oftentimes with constipation, if there's more gas that's produced and then can be passed effectively through the intestines, you can feel bloating with that. Lactose is one of the compounds, so choose less of the high lactose dairy like milk, ice cream, sour cream, soft cheeses like cottage cheese, ricotta cheese, and switch to lactose-free dairy, hard cheeses, and also Greek yogurt is pretty low in lactose. In terms of meat or non-dairy alternatives, beans, lentils, cashews, pistachios, soft tofu, soybeans themselves can be more gas producing, but most meats, milk alternatives, the other nuts like walnuts, peanuts, firm, extra firm tofu can be less gas producing. And then here we have some more gas producing fruits and some less gas producing fruits. So apples, peaches, pears, a lot of times the stone fruit category, mangoes, all dry fruits can produce more gas. And then bananas, grapes, blueberries, raspberries, citrus fruit, guava, kiwi are less gas producing. And then here we have some more and less gas producing vegetables. So the choose less because they're more gas producing are like the artichokes, Brussels sprouts, broccoli, and then also onions and garlic can be more gas producing as well. And so try to choose more of the less gas producing foods such as carrots, cucumbers, kale, spinach, tomato, potatoes, yam are some pretty good options. The take-home messages are optimize your fiber intake, especially insoluble fiber, and aim to have about 25 to 30 grams of fiber a day, unless you have a history of bowel obstructions, severe gastrointestinal dysmotility, or narrowing of the gastrointestinal tract. Make sure that you're taking adequate fluids, so 6 to 8 ounce glasses of water a day. Exercise daily or most days of the week. Don't ignore the urge when you need to have a bowel movement. And then adjust your diet if bloating or gas is an issue. So how strict you are with it depends on your symptoms and also the severity of your constipation. So the more constipated you are, and if you have more bloating with it, you might want to really eliminate those gas producing foods. But if you're feeling your constipation's okay, you can add some of those back in. I really would like to thank Stanford, Dr. Nishati and Dr. Kim, everybody for allowing me to speak today. These are some upcoming other digestive health series webinars that we have.
My name is Zaina. I'm the nurse practitioner over at the Pelvic Health Center. And I've met some of the attendees, and it's great to see you guys all on. Thank you, everybody. And I'm going to kind of go through some of the questions. We have a ton of questions. It's awesome. Thank you, everyone, again, for your patience with our technical difficulties earlier. Just like constipation, we had a little difficulty getting it out. So, all right. So this question is for Sandy. This patient is saying they've been told by different doctors to follow a low FODMAP diet, a paleo diet, a low oxalate diet. They've been on many constipation medications with horrible side effects. And then it gets even worse if they do whole grains, beans, and legumes. What would you recommend?
So in terms of the whole grains, beans, and legumes, it kind of referring back to the FODMAP content of those foods. And so they can make many symptoms like gas and bloating associated with constipation worse, especially if your constipation is more severe. The low FODMAP diet can help with symptoms, but the low FODMAP diet itself may not help with constipation unless you're having the fiber and the fluid and optimizing all the other aspects for constipation. I'm not aware of the autoimmune, the paleo, the low oxalate diet being studied to show an effect for constipation. In terms of the question about what you would add to your diet, I would recommend consulting with a dietitian to get more specific and individualized diet recommendations.
Thank you. The next question we'll give to Dr. Nishatian. How much does medication contribute to constipation, and which medications are major contributors?
Thank you. So, very good question. We know that many of the medications that people take for various reasons, as I said, even the blood pressure medications, many of the patients that we use for pain, whether these narcotics or these are over the counter, let's say ibuprofen, you may know it as Advil or Motrin, they can all cause significant symptoms of constipation. The data that we have, the best data we have available goes back to the narcotics. Opioids, everybody knows, is associated with constipation, and in various studies based on the different patient populations, whether they have been cancer patients or patients who have been taking for non-malignant causes, it seems that the rate of the constipation on patients on opioids have been ranging from 40 to 90%. So many of the other medications that cause constipation, we don't have good data on that, but we know that they can be often a good cause for the symptoms of constipation. In many of the patients who are on chronic medications, unfortunately, we cannot really significantly change the medication because they need to be on the medications for various reasons. And so that's why we try to treat the constipation, and although reversing the underlying pathology by avoiding the medications that are unnecessary is going to be helpful, but this is not always possible, and we appreciate that it's not always possible.
Thank you. We do have some questions going on in the chat, and then there's still other questions. I wanted to touch on one because it's been asked a few times about the do's and don'ts of IBS constipation during pregnancy, and which medications are safe for pregnancy, nutrition, and all of that, since constipation can tend to happen or be more of an issue during pregnancy. So I wanted
definitely. Yes, that's a good question. Definitely constipation can be a major problem during the pregnancy. There are many good reasons for pregnant women to have some degree of constipation. One, because of the hormonal changes. We know that hormones are very effective in terms of slowing down the motility. The diet during the pregnancy is definitely the different. Many of the pregnant women are on iron supplement, and so there are multiple causes. Drinking liquids can be sometimes more of a concern because of the frequent need for having the bladder emptying because of the pressure on the bladder. So these are all good reasons for thinking about constipation during the pregnancy. And the diet that we want you to be taking during the pregnancy, we technically want to have a high fiber diet, which is also enough in terms of the nutrients, because proper nutrition is going to be very important, especially during the pregnancy. We want you to really have all the vitamins and nutrients and really avoid any skewing your diet to one way or another is not going to be what we want. And fiber is going to be very effective in reversing the symptoms of constipation along with enough hydration. But in some patients who have significant constipation, the symptoms do not respond to the fiber supplement. In these patients, we could consider use of the different laxatives. I always want to really run these with the OB, and because they know best. But we know that the magnesium hydroxide, magnesium salts are definitely safe during the pregnancy. They have a really low profile, very safe, and they have been very good tolerated during the pregnancy. Lactulose has been used. There is not enough data behind it. Bisagodil or Docolax is also some other options that can be used. I definitely want you to talk to your OB before you take them because, again, these are all safe options, but each individual may have a specific concern related to the pregnancy, and this is going to be best to be run by the OB. Miralax is also, or polyethylene glycol is another good option for pregnancy. There is no data out there, but usually it doesn't have any systemic absorption. So technically there is no concern as it's not going to be absorbed, and so it's not going to get through the placenta.
Thank you very much. I just wanted to briefly touch on the time. I know we had a late start, and so if our panelists and everyone is okay with going till about 6:10 to kind of compensate with that, for that, if that's all right, because we do have a lot of another question here is about, you know, there was the mention of the SMART pill study for slow transit motility. We see a lot of patients who have difficulty with insurance coverage, and they'd like to know what are alternatives in order to further investigate that.
Yes, it's correct. It's really painful for our patients and even for us not to be able to get these tests authorized by the insurance companies. And about the SMART pill specifically, this is one test that I know that I will never be able to get it authorized if it's not approved. And the reason is because many of the insurance companies don't want to just pay for it. So we can use this, the marker capsules. You may know it under the SITS marker test. That's a simple, much cheaper test, and that's the one that we usually use to get a better understanding of the colonic transit. It doesn't provide as much detail as the SMART pill will or the wireless motility capsule will provide, but it's a good enough surrogate for the colonic motility and can be used in specific patients. If there are concerns over the slow motility in the rest of the GI tract, we can also use the scintigraphy. And again, the scintigraphic evaluation at Stanford, we sometimes can get that approved for some of our patients for the whole gut transit as well.
Okay, thank you. I'm sorry, I was told my audio was breaking up, so I hope this is better for everyone. Another question we have here in the chat is, does cortisol affect constipation, and is weightlifting considered exercise for this purpose? I don't know if maybe
yes. So we don't have any direct data on cortisol and the symptoms of constipation. We don't really know exactly, but the weightlifting is an interesting question. So weightlifting is not a typical physical activity that will be affecting your colonic motility. And in certain patients who may have some degree of pelvic floor disorders, whether these are hypertonic or hypotonic pelvic floor disorders, weightlifting might not be the ideal exercise or physical activity for them, just because of the Valsalva, the pressure that is induced in the abdominal cavity. That can be aggravating the pelvic floor if this is prolapse, or basically cause further problems with the pelvic floor issues. So for patients who have problems and they are going for the exercises such as weightlifting, we definitely want to have a personal, individualized discussion with them.
All right. Here we have a question on the association of Hashimoto's with constipation.
Thyroid problems can definitely be associated with constipation. We technically associate hypothyroidism with the constipation and dysphoria transit. However, in the Hashimoto, there will be some levels of the hyperthyroidism during these periods. Maybe there is some degree of the diarrhea even involved. And then after that, this is going to be the significant decrease in the hormones, thyroid hormones. And this is the time that is likely to see some levels of constipation in those time periods, for sure.
Thank you. There's a couple more here. If someone is diagnosed with an elongated colon, is there anything to help with constipation in that specific situation?
So if I get the question right, the elongated colon to improve the symptoms of constipation in the patient with elongated colon?
Correct.
Right. So this is an interesting question, comes up in the clinic every now and then, that patients go for a colonoscopy. They have been told that they have a redundant colon or elongated colon. And so the truth is that the reason for redundant or elongated colon majority of the time is because of the basically more of many of these patients have slow transit constipation. So many of patients who have the symptoms of constipation in the setting of the elongated colon, they may need to have really some help for the constipation management. And if they, again, it doesn't really matter, we start with the fiber. If it's not tolerated well, we use the osmotic laxatives, we move on, and we'll try to find a nice balance. But this is, again, depends on each individual. Not every person with a redundant colon is going to be on multiple different prescription medication, but there are some patients with the redundant colon who are going to need more help in order to improve the symptoms of constipation. Depends on the lifestyle as well.
Okay. So for Sandy, a lot of our patients are asking about places that they can get good resources for lists of FODMAP diet, and I think they wanted to know like more about a principal low FODMAP diet, any kind of particular website that you recommend for that. And maybe if you know some examples of magnesium salt.
So the Monash University, it's a university in Australia, and they're the ones who developed this diet, and they're the ones who are testing the FODMAP contents of the food. They have a website that's really helpful. You can Google Monash University FODMAPs, and it'll show up. There are...
So I can send it to everyone?
Yeah. Let me...
Oh, sorry.
I'm just gonna type that. So there are other websites out there, but this is probably the main one that I use. There's meal plans, there's recipes made by specific authors. I'm gonna name one by Kate Scarlatta, and then another one by Patsy Katsos. Are some good ones. There's also brands that specialize in low FODMAP condiments and foods. For example, Foddy's is one of them. So there's definitely a good amount of information out there.
Okay, thank you very much.
I can answer the question about the magnesium salts.
Oh, yeah.
So the magnesium hydroxide is very effective. Magnesium citrate, most people have taken it or may know it from the use prior to the colonoscopy. So it's a syrup, it's a basically clear syrup, but also it can be found in the form of a powder. And the powder can be very effective as well. Also, there are some capsule forms of the magnesium citrate that can be very effective. So milk of magnesia is another formulation of the magnesium salts that is also quite effective. Some people don't like the chalky taste of it, but in general, it's a very effective medication for constipation. It can also be available in the form of the tablets, and again, that's another form of the magnesium.
All right. And then I think this might be the last sort of loaded question with many components. And several patients have asked this in one form or another in regards to buildup of tolerance to certain medications, such as Linzess and Motegrity, and what the cause of that is, and what their options are, as well as what are some of the long-term side effects of being on these medications for many years.
Right, very good questions. And this again comes up a lot in the clinical practice as well, the tolerance to the medications. And it's interesting that there is a gap of knowledge between what our patients are experiencing, developing some degree of tolerance, and feeling that the medication is not as good, working as well as it used to work 3 months ago. But for us, in terms of the research and medical knowledge, this is a clear gap. We don't really know why this happens, and we think it should not happen, to be very clear here, because in terms of the mechanistics of these medications, they are working on the ion channels. There is no knowledge if there is any upregulation of these ion channels to the point that the tolerance is basically happening. Based on our clinical studies, these medications should stay very effective for a long-term use. But in practice, I know that this is commonly happening. And again, we acknowledge this is happening in some patients, but we don't really know what is the cause of that. Sometimes giving a holiday in terms of if Linzess has been working, or if this over-the-counter medication has been effective for a couple of months, and then you feel it's not really as effective as it was before. Whether this is really because of and it can be related to the diet, it can be related to the physical activity, despite the fact that we think we can keep control everything in a certain level, we have to admit that there are certain areas that are out of our control. And so seasonal effects, if this is our mood, if this is the microbiome, if any of these are the cause of the development of this tolerance, we don't really know. But sometimes we can say that hold the medication, give a holiday for a couple of months, use another agent, and then after a couple of months, maybe after 3 months, after 6 months, come back to the agent that was working initially well. And sometimes by doing this practice, rotating between the different medications, we can actually, again, build up some level of efficacy for these medications and find it helpful. Regarding the long-term use of these medications, many of these medications are new. So like Linzess has been only available in the market since 2012. Trulance or plecanatide got approval back in 2018. So there are limitations in really knowing the very long-term effect. But as far as we know, the data that is available based on the FDA approval and the FDA monitoring that is ongoing, it seems that these medications are very safe and there are no significant side effects associated to them as far as FDA has been following.
The last part of that, sort of as a quick follow-up question, I know we're over time, is there any issues with combining Miralax with any of these other secretory or motility agents?
No, indeed, I want to say that having a combination of medications is a better choice in many of our patients. rather than going with single agent and decide based on a single agent if you want to keep it or not, because the different medications may have, as I told you, have different mechanisms of action, sometimes using a couple of them to have a better synergistic effect can be more effective. And so it doesn't mean that if you are taking one medication, you have to avoid the other medications.
Okay. Thank you very much. It looks like we've gone over our time. So it was...
Right. Thank you very much. I want to thank everybody again, our organizers, Sandy, Zaina, and Dr. Kim, Shannon, Michelle, Tony, everybody who has been really helpful in providing this platform again. I want to thank all our attendees because of their patience and all the glitches that happened. I know that many of these questions have not been answered, and we will try to get them answered and maybe write down to you. Thank you.